With this said, let's start, and I'll take it in the sequence. I like the sequence that you brought up, and it probably will make sense. So, Andrew, let's talk a little bit about the short of the sorafenib, which we all know about. Tell us a little bit about lenvatinib. What's the story there?
So lenvatinib is, I think you can view this is another TKI, but on the other hand, this is actually a more potent inhibitor against VEGFR2. I think there's no argument this is a very potent VEGFR2 inhibitor among many other potential inhibitory targets. And so in a very, very well-conducted landmark study, so-called reflex study, and the drug was really comparing directly against sorafenib. And interestingly, if you look at the overall survival, the drug actually meets the positive endpoint of non-inferiority, meaning that the drug is actually behaving not inferior to sorafenib in terms of the overall survival. However, if you look at the important secondary endpoints, including response rate, PFS, TTP, I think the drug is definitely more in favor of sorafenib with all the secondary endpoints being analyzed. So I think for that reason, I think this is definitely a legitimate option in the first-line setting for patients with newly diagnosed advanced stage HCC. And also, we all know this drug is different from sorafenib in terms of the safety profile. I think we're very used to the sorafenib, related side effects, including the hand and foot skin reaction, the diarrhea, the fatigue. But lenvatinib also has this unique pattern of safety profiles. We see more hypertension as predicted. We see, patients, perhaps, may having, worsening ascites occasionally. So I think the safety profile is definitely different. But overall, I think both drugs, we have learned how to deal with the safety profile. I think if it's a well-trained oncologist who are very vigilant, we can definitely get our patients through the treatment with very close monitoring. So I'm glad that, this is becoming another option for our patients. Yeah.
Absolutely, I agree. If anything, at this GI ASCO 2019, there was a nice abstract that was reported by Dr. Kudo from Japan that looked at an analysis of the response and survival on the reflex study, exactly what Andrew referred to. And if anything, it was a nice exercise because the median overall survival for the responders to the lenvatinib was 22.4 months, and for the non-responders was 11.4 months. And if anything, the conclusion was it's independent predictor, response is an independent predictor of overall survival, which is exactly what we like to see in all those. And I totally agree that this is quite intriguing in that regard. Katie, along that line, lenvatinib, have you had hand-dose experience? The fact that the drug is approved now. So please tell us a little bit about your experience per se.
Yes, we've started using it this fall, really, since its approval. And I have to say, it's as Andrew described, the main toxicities that we've encountered have been hypertension and some edema. Haven't had any hand-foot syndrome, which is, as expected, much lower rates of palmar-plantar erythrodysesthesia than with sorafenib. And so I think is in the family of TKIs that we've become familiar with in terms of the monitoring requirements needing to have. I think one of the key points is having, for all of these TKI family drugs with anti-angiogenic activity, is to have really strong blood pressure control prior to starting the drug. I like to have my patients with a blood pressure reproducibly less than 140 over 90 at tops before starting a TKI, whether it's particularly lenvatinib, but also for sorafenib, rego, and cabo. All of this family of drugs can cause hypertension that's problematic on treatment and requires dose interruptions if not well controlled going into it and not monitored closely. So I think that's the main key for me with lenvatinib is tight blood pressure control going in and close monitoring, especially the first few weeks on treatment at the 12 milligram dose for people who are more than 60 kilograms, or 8 if they're less than 60.
Fair. And last point on the lenvatinib, and Rich, you've been involved quite a bit, and you're really one of the experts who really understand lenvatinib quite well. No doubt that the study was designed as a non-inferiority study. I would love very much if we can hear for our colleagues who are watching us, what exactly is non-inferiority? And number two is, tell us a little bit more about the real results of the reflect in regard to response, PFS, etc., because there was quite a big wealth of information there.
Sure, and I commented before, for the the last decade, we haven't had a drug that has beat sorafenib, and we still don't, right? Because this study was designed to show that by being non-inferiority, that there's a very tight window statistically that the results of this drug compared to sorafenib are the same, right? That survival, and ultimately in the study, the survival was 13.6 months with lenvatinib, about 12.3 months with sorafenib, and that this was the first study of an active control for for a new drug, lenvatinib versus sorafenib, that met its primary endpoint of non-inferiority, meaning that lenvatinib has similar activity as sorafenib as far as the primary endpoint of OS. Because it met the non-inferiority endpoint, they were going to look at superiority, and it did not meet that endpoint. But Andy alluded to this before about the secondary endpoints, right? And because it met a primary endpoint of non-inferiority, we can look at the secondary endpoints. And we saw that on all of these, there was a benefit to lenvatinib, a better control of tumor progression radiographically as measured by TTP, a significant increase in PFS, and a significant increase in response rate. And this is the first time we have a drug that has a fairly good response rate, right? And in this study, they used the modified RECIST criteria, which is looking at the changes in enhancement of tumors. But whether by modified RECIST or the traditional RECIST, which is just looking at the size of tumors, lenvatinib essentially doubled that of sorafenib. And so the question for us is, how important is response in advanced liver cancer, right? Because again, for the past decade, we said response is not important because it doesn't affect OS. And now we have a drug that does induce a response, and in the overall population, survival's the same, right? Non-inferior. But at this ASCO GI 2019, you alluded to the work by Dr. Kudo that shows that if you have a response to either sorafenib or lenvatinib, right, either drug, your survival is better than if not. And this is a very intriguing idea, you know, especially if we're trying to differentiate these two drugs. You know, if we have a patient who has a big tumor burden and, you know, we think getting that disease under control is more important than just stability, then maybe that's a patient we'd lean more towards lenvatinib. At the same time, the REFLECT study excluded patients who had more than 50% of their liver involved, or they had main portal vein invasion, right? Maybe those are patients we might feel more comfortable with sorafenib. If you look at some of the other secondary or subgroups that were looked at, you know, historically patients with hepatitis C have done better with sorafenib than the hepatitis B cohort. With lenvatinib, it seems somewhat similar. The high AFP patients seem to get a little more benefit from lenvatinib versus others, and this higher tumor burden. So some things to think about. At the end of the day, the primary endpoint, non-inferiority, survival, which we would all, I think, agree is the most important endpoint, is the same. But in reality, with a patient sitting in front of us, we have a choice. And, you know, I think we'll discuss how we choose.
Sure.